Hello, everyone. I'm Mirvat Al-Asnaj, and I'm the Research Director at King Fahd Armed Forces Hospital. It gives me tremendous pleasure to introduce the faculty that we have today. David Cohen, he's the Director of Clinical and Quality Research at the Cardiovascular Research Foundation, and Jung Min An, who is one of the investigators of the PREVENT trial that was recently published in the, was it New England Journal of Medicine, right?
No, Lancet.
Lancet. Sorry, I'm a little off there. But it was very interesting study, and we first want to hear from the investigator a little bit about the trial itself, the design, the principal findings, and then we're going to go ahead and dissect it and discuss it. Please do raise your hands or put a question in the Q&A if there's something that you'd like us to address. But June, I'm going to turn it over to you, and please go ahead and start with your slides.
Can you see my slide?
Yes.
Yeah, good afternoon, Saudi Arabia. Actually, this is my first presentation for Saudi Arabia. Thank you, Dr. Mirva, for having me here. So I'd like to introduce and talk about our recent trial, PREVENT trial. I'm Jung Min An from Asan Medical Center, South Korea. So what did you know? The last several decades, there has been a lot of research about vulnerable plaque. So based on the autopsy trial, some plaques easily ruptured and making the acute thrombosis and causing the acute coronary syndrome. Thanks to the development of intracoronary imaging, IVUS imaging, VHI-IVUS, OCT, and NIRS imaging, so we can define some vulnerable plaque that cause increasing the risk of a coronary event. In addition, in each imaging device, nicely demonstrate that if there is some characteristic of a high-risk plaque, the coronary event risk increasing. In addition, some combination increase the risk further. So in addition, what do you know? So we can define the high-risk plaque in vivo using intravascular imaging, so any kind of imaging. In addition, intracoronary imaging defined high-risk coronary plaque has more tendency to increase major adverse cardiac events. Then what we don't know yet is, can you prevent future events originating from vulnerable plaque, high-risk coronary plaque using local treatment like the PCI? Yes, there has been a small randomized trial to evaluate the preemptive revascularization with the stent or other BVS on high-risk coronary plaque. This is the most representative randomized trial, PROSPECT 2 trial, shows some decreased risk of event, but because of limited statistical power, p-value does not meet the significant. So we plan the PREVENT trial. PREVENT trial is a preventive PCI versus medical therapy alone for treatment of vulnerable atherosclerotic plaque. S.A. Bach is a PI, me, and Greg Stone and Dieter Park is the investigator of this trial. So the objective of this trial is to assess whether focal treatment to preventive PCI of non-flow limiting vulnerable plaque, imaging defined vulnerable plaques improves clinical outcomes compared with the optimal medical therapy alone. We defined the vulnerable plaque based on the previous trials. If coronary angiogram, in the angiogram, coronary stenosis is more than 50%, if you measure the FFR negative, that means non-flow limiting plaques, and meeting 2 out of 4 criteria: minimal lumen area less than 4, plaque burden more than 70%, thin cap fibroadenoma by OCT or RF-IVUS, lipid-rich plaque by NIRS. So 2 out of 4, because we need higher risk. We have to identify the higher risk of plaque than the PCI treatment is. The risk of PCI treatment recruitment itself. Again, our definition of non-flow limiting pulmonary plaque is first, angiographic stenosis, significant stenosis, and FFR negative, and meets out of 2. Minimal lumen smaller than 4, plaque burden more than 70%, thin cap fibroadenoma by OCT or RFIs, lipid-rich plaque on nears. So 2 criteria means the morphology, 2 criteria means the composition of plaque. So during the initial recruitment period, PCI was performed with BVS. Following the withdrawal of BVS, giant stent were used for default device of PCI. Imaging guided PCI was performed in all target lesions. This is a procedure. Angiographic significant stenosis, FFR negative, perform intracoronary imaging, assigned to the preventive PCI group, and implant the BVS stent, BVS. Primary endpoint was a target vessel failure, a composite of death from cardiac causes, target vessel myocardial infarction, ischemic-driven target vessel revascularization, or hospitalization for unstable or progressive angina at 2 years after randomization. This is the patient flow. We screened 5,600 patients. We measured FFR around 40% FFR positive, 60% FFR negative, and then evaluated the imaging. So finally, we enrolled in this trial 1,608 patients randomly assigned to the preventive PCI 800 patient, OMT 800 patient. So enlist the follow-up primary endpoint at 2 years, 97% of patients completed 2-year follow-up, and final follow-up completed 95%. Analysis 100 patients included in the intention to treat analysis. This is a patient characteristic. Patient age was 64, diabetes 30%. This is interesting finding is a clinical presentation, mostly stable and silent ischemia 83, relatively unstable non-STEMI acute coronary syndrome is relatively rare, only 17%. And qualifying criteria for target lesion, mostly small minimal lumen, large plaque burden, 97%. The nearest defined lipid-rich plaque is 28%. Think fibroadenoma is only 7%. LAD is the most common the target lesion. Mean FFR value was 0.87, 0.86. Diameter stenosis by QCA is 57. Minimal lumen is 1.3. Lesion length was 24. So for the target lesion, 2/3 of patients received the giant stent implantation. 1/3 of patients received the BVS implantation. And in addition, overall patient, 1/3 of patients received the PCI in non-target lesion. This is a proportion of high intensity statin and moderate intensity statin plus ezetimibe therapy. During the follow-up, the 2/3 of patients received the high intensity statin therapy. During the follow-up, a final follow, mean LDL level is 64, very similar LDL level to the clinical trial for the high-dose statin therapy. This is a primary composite outcomes, target vessel failure at 2 years. For OMT alone, it's 3.4. The preventive PCI plus OMT only 0.4. P-value is very significant. Up to 7-year follow, OMT alone is 9.4. Preventive PCI plus OMT is 6.5. Significantly decrease the primary composite outcomes by preventive PCI. This is another important patient-oriented composite outcome. Death from any cause, any AMI, any lipid intervention. Up to 7-year follow, OMT alone 9.3. Preventive PCI plus OMT group 14.4. Significantly reduced by preventive PCI. Even patient-oriented composite outcomes. This is in detail of primary composite outcomes. Deaths from cardiac cause, there is some tendency reduced by the preventive PCI, but p-value is not significant. Target vessel MI as well, mostly due to the TVR and hospitalization is the main driver for the positive result for preventive PCI. This is subgroup analysis at 7-year follow-up. 3 component subgroup to show that the significant P4 interaction, presence of non-target vessel PCI, and minimal median diameter stenosis more than 55 and less than 55% by QCA for target vessel, target lesion, and preventive PCI modality, PVS or GIANTS. 3 components to show that the P4 interaction on the clinical outcomes. So this is a first conclusion for primary effort of PREVENT trial. PREVENT trial is the first powered clinical trial to evaluate the preventive PCI on non-flow limiting polymer plaque. This trial showed that the preventive PCI plus OMT resulted in the lower instance of MACE compared with the OMT alone in patients with non-flow limiting polymer plaques. Our key findings might provide novel insight on the role of preventive PCI on non-flow limiting high-risk polymer plaque in the future. In addition, I prepared several more sub-studies. More sub-studies already presented in the this year TCT. Oh, this is my rubbish thought. So I'm thinking polymer plaque is very similar to the pimple. This is actually polymer plaque. This is ruptured plaque. This is erosion. Some pimples are needed to, yes, usually the cleansing and systematic medical therapy, but some pimples need local therapy. Additionally, we observed the predictors of cardiac events. So, and in addition to which regions more effective by the preventive PCI, according to the NIRS, diameter stenosis, and presence of non-target vessel PCI and BVS versus the DES concern. So one of my fellows presented the predictors of cardiac event in preventive trial OMT groups. This is very interesting. We had 4 imaging criteria: small lumen, large plaque burden, fibrotheroma, lipid-rich plaque. Of 4 criteria, after adjustment, only 2 components remained: plaque burden and high lipid-rich plaque. So 2 components are the most important and independent predictor for cardiac event in optimal medical therapy groups. Plaque burden linearly gradually increased the risk according as the plaque burden increased. But minimal lumen area, no association between the minimal lumen area and cardiac event. Another component was lipid-rich plaque. Lipid core burden index is linearly associated with the increased risk of cardiac event. So I think this is a very important subgroup analysis. So we also analyzed the efficacy of preventive PCI of polymer plaque according to the lipid core burden index. So in our trial, arbitrarily we defined the high lipid-rich plaque defined as more than 315 lipid core burden index. When we grouped into the high lipid-rich group, high lipid-rich plaque and low lipid-rich plaque, so only clinical benefit was observed only in lipid core burden index more than 315 groups. So this is very interesting findings. Lipid-rich plaque, non-lipid-rich plaque, even under the medical treatment, so patient lesion risk does not increase. Preventive PCI or OMT, no difference. But high lipid-rich plaque, when you treat them medically, event rate is significantly increased over the medical treatment, over the preventive PCI. So this is similar in the patient-oriented composite outcomes. So non-lipid-rich plaque, no difference between the preventive PCI and OMT. Lipid-rich plaque, so OMT significantly increased the risk of cardiac event, patient-oriented composite outcomes. Another interesting finding is one of the subgroup analysis, angiographic diameter stenosis, similar findings. Higher diameter stenosis, we observe the effectiveness of preventive PCI, but less severe coronary diameter stenosis, there is no difference between the OMT and PCI, preventive PCI. So another thing is the presence of non-target vessel PCI. Only the effectiveness of preventive PCI was observed in patients with non-target vessel PCI. So which device would be better than the other for preventive PCI? So BVS cohort, there is no p-value yet. The preventive PCI using BVS numerically reduce the risk of cardiac event, but p-value is not statistically significant. But the Giants cohort, the p-value is very significant. For this is a second summary of our subgroup analysis. Preventive trial, preventive PCI plus OMT resulted in a MACE, but preventive PCI would be more effective in regions with higher lipid core burden, high lipid content, and more severe diameter stenosis, and in patients with non-target vessel PCI. Of those, I did more analysis, but because of a very small number of subgroup patients, I cannot make a firm conclusion, but this three-component, lipid content, severe stenosis, presence of non-target vessel PCI is linked with, I think I observed that the high lipid burden. So diameter stenosis, patient have a high lipid burden compared with without non-target vessel PCI, patient with a target vessel PCI have a higher lipid content. In addition, contemporary DES appears to be safe enough to use it as a device for preventive PCI. But yes, I admit that there are many cons for preventive PCI. IK Zhang, so the MGH, Mass General IK Zhang, sent me this kind of slide. Yeah. Hey, Dr. An, atherosclerosis is a panvascular process. Plaque phenotype changed over time. 3/4 of plaque regression with medical therapy, subclinical plaque disruption and healing contributed to the plaque progression, and plaque erosion is responsible for another significant proportion of ACS. So he didn't agree with the preventive PCI at this moment. But but I truly believe that the clinical application, how to apply these findings in our clinical real-world practice, we need more research. But I do believe that our trial make us to stand up another starting point for future coronary plaque study. Thank you for your attention.
Thank you. June, this was a remarkable trial, first of all. So thank you and the other investigators for actually doing a trial like this, because it's teaching us to think ahead of time. Why wait for an event to happen? And this is the direction that we're hoping that we prevent events from happening rather than treat after the fact. So is stent the solution to prevention? I think that's the question that this trial was answering. I'm going to give David the floor. Before I do that, really quickly, I just want to ask a couple of questions that came up in the chat that I think are important to address for our wider audience. And one is, we're talking about lipidic plaques, that those are more vulnerable than stable calcified plaques, and this is what your study showed. What about the LDL and lipid management in both groups? How well managed was their lipids? And the other one was the antiplatelets regimen. If you could kindly comment on those.
Yeah, this is a very important question. I showed us one slide that mean lipid level, LDL level during the follow-up was 64. Actually, during this research period, we don't have a PCSK9 or other the more potent drugs. So we can only prescribe the high dose the statin or the uh, intermediate intensity statin plus ezetimibe. But during the follow-up, 64 milligram per deciliter LDL level is, I believe that quite well the managed lipid level, I think. In addition, frankly speaking, the patient with a preventive PCI had a more potent antiplatelet regimen because the patient had the stent already. But actually, there is no study to show that potent antiplatelet therapy improved the patient outcome in stable patient or the vulnerable patient with the vulnerable plaque. So I believe that we need more study on these regards. Thank you.
David, thank you.
Yes, thanks. Thank you, Mirbot. Jungmin, great presentation as always, and really a very interesting. And I think you really hit the nail on the head when you said this is the start. You started this trial, I think 2014. I think I was, I remember reading the protocol back then and talking to SJ about it and thinking, wow, this is really an amazing attempt to do this. And I really am thrilled to see that it came to fruition and you were able to complete the study. And it has results that are very consistent with the other smaller studies, especially the Swedish study that was recently published. So it looks like something that we can do. I think from a methodologic standpoint, this is a tricky area to study. The main reason being, if you think about it as a practicing clinician, from a study standpoint, it's much more efficient and much more usual to focus on the lesion or the vessel that is being intervened on. And that was your primary endpoint, had focused endpoints of target vessel myocardial infarction and revascularization of the target lesion. But I was very pleased to see that this benefit extended to the patient-centered composites as well. Because from a clinical standpoint, we care about the patient, and if they have a MI from another vessel and die from that, that's not a good thing. That still is a very bad outcome for our patients. So I think it's very important to make that distinction. I would note a couple of things. One of them you already focused on, but I just want to mention how important it is this idea of looking at the co-medications and the co-interventions that are happening in these patients. We always focus on the randomization, and that is very critical to start. Randomization assures that we start with a balanced population. We start with patients who have an equal chance of being in both groups. But in the ideal world, you would do this trial blinded as well, right? You would do this study. You wouldn't tell the patient if they got a preventive PCI or not. You would treat everybody with dual antiplatelet therapy. You would treat everybody with the same level of lipid lowering. And the idea of that is to, the randomization helps to balance things up front, and then the blinding, or at least using protocols to manage the lipids and other things downstream, ensure that the patients also remain the same after the treatment, which is very, very critical. I think that you did a good job of showing that the lipids were similar in both groups. And as you just acknowledged, the antiplatelet therapy did differ, but previous studies have not suggested a benefit in the non-PCI setting. So I think it's fair to say that probably would not have changed the outcome very, very much.
Can I mean, your area of expertise is really clinical outcomes as well. Mm-hmm. And so for an individual practitioner, such as myself, when we look at the results of this trial, technically, it is a positive trial.
Oh, it's
But
definitely.
how, yes. So will it change my practice if I take into consideration that it took 803 PCIs to prevent 13 only cardiovascular events over the course of 4 years? So the effect of that, the magnitude effect of it, of which some of them were hospitalizations for unstable angina, some of them were ischemia-driven TBR. So not only two were cardiac deaths actually in that
I
group.
think it's a great question, and it's obviously is the important question, and this is to some degree the question that IK Chang was focused in on, and that most of the thoughtful critiques of the study are come in as to play as well. Is that are we going to bring a patient into the hospital? Let's say you have a patient who's had a cardiac CT and has suggestions of vulnerable plaque on the cardiac CT. That was not part of this study, but I'm just imagining how one might operationalize this in the future. You have a cardiac CT, and we can these days increasingly we can measure MLA, we can measure the plaque burden, the plaque volume. We can measure not necessarily the lipid content, but we can look at calcified versus non-calcified plaque. We can look at attenuation level. So there are things we could do, but are we going to then take that patient and say, you're high risk for an event, and we want to bring you into the hospital and subject you to an angiogram, to imaging, and then to treat what we find that meets Jungmann's criteria with preventive interventions. I think that's a little bit ahead of ourselves, because what are we going to tell in the benefit, as you said, that we can tell the patient about is most of it is going to be avoiding another PCI. There is some reduction in myocardial infarction and trends in the right direction towards mortality. But I think in order to do what I just described, we probably need studies that are really focused on, don't take the lesion out of play, look at the patient-centered composite endpoints of death MI, and maybe any revascularization, but probably death MI. That really is the endpoint we need. If we're going to treat PCI like a preventive therapy, we need to study it like a preventive therapy. We need to think of it like primary prevention with statins or something like that. So I think we're a little, that's a little out there. I don't think Jungmann is doing that yet. Jungmann, are you doing that yet?
Yes, we are planning the preventive trial too. We are planning now, but yeah, but yeah, definitely we have to target for the DSMI endpoint. But if we target for the DSMI, we need 10,000 patients to maybe.
Yeah, that's right.
Yeah. So we are figuring out how to compromise the ideal situation and practicability to performing the practice. So this is a big problem. So I want to say is that for me, I measure I always measure FFR in the intermediate stenosis. So the physiology guided PCI is a class 1 indication in nowadays, particularly for stable angina. And the procedure is very straightforward. Above the 0.80 deferred, less than 0.80 PCI is justified. But in our trial, made a small gradient in such kind of a very straightforward FFR guided PCI. If the particular in patient with the non-target vessel PCI, for example, LAD is very tight, RC is intermediate, FFR measured, but for your visual estimation, very tight, but FFR is negative. So during the LAD intervention, you may have some imaging catheter. You can evaluate the RCA, and RCA is a large plaque burden, small lumen. Then putting the stent using the contemporary second generation DES could be justified based on our trial.
I totally agree with that. I think that's the one place where it might have some practical utility today is, where you don't have to subject the patient is already there. The patient is already sedated on the table. You have vascular access, all of those things. And as Jungmann said, it's not that big of a deal to take. You've got a patient with an intermediate lesion that you image and then make a decision based on the imaging. I do think that is that if I were writing guidelines based on this, I might, that could potentially, get a class 2. I don't think it'll get a class 1 without confirmatory studies. But I think, as what you've shown here, and you made the point in your slides, is that preventive PCI in this, on these types of lesions is very safe. And that's really critical, right? If you're doing any type of preventive intervention, whether it's, again, it's a preventive PCI, whether it's a closing a PFO, whether it's treating an asymptomatic aortic stenosis. If you're going to be treating patients, who are at low risk for future events, to prevent future events, we have to really have safe treatments to do that. And I do think this study showed very clearly that the downside risk, other than the cost of buying one extra stent in those patients, because that's really what it is for these these patients when you're already on the table. You don't have the extra expense of bringing them in the hospital, of the starting to antiplatelet therapy. All those things are already given. All you're doing is putting one more stent in, and I think that is a possibility.
I just want to ask here, the study A is very consistent with other trials, including non-invasive imaging trials like CT scan, that actually showed very similarly that percent stenosis or diameter stenosis, plaque consistency and plaque burden, particularly lipidic plaque, perhaps even thin cap fibroatheroma, are probably the vulnerable features of plaque. What I do want to ask you, though, is that we all know that intracoronary imaging, particularly in other parts of the world, I know the uptake in Asia is very high, but in the other parts of the world, it's actually very low. And these are very specific definitions, to identify a vulnerable plaque. It's not just identifying plaque, but the vulnerability of the plaque, and so on, and the consistency of it, and the percent of burden and volume of the plaque. Are we really ready to start expecting interventional cardiologists across the globe to be imaging to identify vulnerability in the plaque? What do you think?
So first of all, we need more study actually. So the key to success is key to success of this trial is a very low rate of preventive PCI, event rate of preventive PCI. So this is very important. So just answering to your question, I want to say is if we do something, then under the IVUS guidance, you have to optimize your stent region as much as you can get. So this is very important. Then in addition, what is the real vulnerable plaque? So we actually need more studies. Most of the data came from the observational studies, and then different patient characteristics, different countries, the risk would be different. So in addition, the all intravascular imaging is a very invasive procedure. So as mentioned by Dr. Cohen, so actually in the future, the CT will give us some hint for how to detect the vulnerable plaque. So next, the TCT-AP, the April, I'd like to present the kind of sub-study from PREVENT trial to compare the CT findings and the effectiveness of PCI outcome.
TCT Middle East too, you can present that stuff in TCT Middle East, spread the knowledge. But since this is a journal club, and I want to make sure that our attendees who are new to research and want to learn about research, I want to ask you both two very quick questions. So we did talk about operator expertise, and a lot of the trials that we see on TAVR or other procedures, we're very selective that we wanted the operators to have a certain level of expertise. How does that impact results, and how do you interpret results depending on operator expertise? How does it impact the results and how you interpret them for practice? And number two, David, you kind of did mention it, and I think June, you mentioned it at some point as well. And it was, how do you determine sample size? So when you're looking at particularly preventive trials, how do you determine size of the population that is necessary to give you the power for the results that you're looking for.
Jungmin, you take one of the questions, I'll take the other.
No, no, I think you are the more expert than me.
You're asking me, okay. All right. The expertise is very relevant, and because interventional cardiology is a procedural field, and procedures require a certain amount of expertise, I wouldn't want to have anybody on the street come and do my PCI if I needed it. Then we do have to pay attention to that in interpreting the results of the study. And most papers will say appropriately that we don't know if we can expand this beyond the centers that did the study. And so what will be important to try to understand that ultimately will be registries of patients undergoing preventive PCI if this ever becomes something we are doing more routinely to really be sure that's as safe as it was by the PREVENT investigators. Because as we mentioned before, in order to justify a upfront intervention to prevent later events, you can't be having 2 or 3% procedure-related myocardial infarction, or all the benefit of the therapy will be gone before you even leave the cath lab, because you'll have you have all those events that you have to catch up from. And the example of this, where it's been most used in practice, actually, at least in the United States, is carotid endarterectomy. So carotid endarterectomy, there are 2 indications for it. There is patients who are symptomatic, having intermittent TIAs or neurologic symptoms related to a very high-grade carotid stenosis, and there the benefits are unequivocal and nobody questions. And then there are the asymptomatic patients, which are detected by ultrasound often, or a CT, and are concerned, or their doctor is concerned, there may be features in the plaque. And there, the benefit takes quite a long while to emerge, and it's much more tenuous. And so the surgeons have always made a point of saying, in order to justify doing this preventive procedure, you need to have results that are like those from the surgery that was done in the ACAS trial that originally proved that preventive carotid endarterectomy was a useful intervention, and that was less than a 1% peri-procedural stroke rate. And so we will need to monitor that if this becomes a real treatment. You would not want to go to a doctor who had a 5% peri-procedural MI rate to get your preventive PCI done. The second question, the one about statistics and trial design, is very important. And Jungmin was alluding to this earlier. We always, when we do a randomized clinical trial, we make a point of doing these, what we call power calculations or sample size calculations. And to do that, we estimate, usually based on prior experience or the literature, what we expect the event rate to be in the control group. And that was done in this trial. I forget what, I think you thought the event rate would be something like 12%, Jungmin.
Yeah,
Is that right?
Right.
And then you say, well, what would be a treatment benefit that we would consider to be meaningful as a clinician? That's what you're supposed to do, at least. That's not always what is done. Sometimes it's a bargaining position between the clinicians who say, I want, I would think a small benefit is useful, and the administrator who looks at the budget of the trial and says, we can't do one that large. We have to be more practical. But the idea is to estimate what the event rate is in the control group, what size of a benefit you would consider clinically relevant. And then there are computer programs or statisticians who can help you very easily to calculate a sample size. And then you have to look at your sample size and your budget and say, do they match? And so it's a bit of a dance. It's a bit of a compromise negotiation back and forth between those two, but that's what you need to do. And I think that's what Jungmin was alluding to. And I gave a debate with Greg Stone about this a couple of years ago at TCT. And I think he was favoring, we're ready to treat vulnerable plaque. And it was before the PREVENT trial. I was saying, that's a little too far at this point. And I'm concerned that the trials to test it are enormous. Which is what we just heard from Jungmin. If you do the right trial to test this and use death or MI as the endpoint, you get a 10,000 patient trial, which means you probably have to screen 30,000 patients to get your 10,000 patients. And so it starts to look like one of these monster lipid lowering therapy trials, which is probably correct because this is basically the interventional cardiologist's version of lipid lowering. So I think it is, and at some level, that's telling you something. That's telling you that the effect, whatever the effect is, it's not going to be enormous. And part of that is because we're treating a systemic condition with a local therapy. Treating a systemic condition with a local therapy is challenging. And so you really have to be able to predict these very high-risk patients to do it. I mean, I think it's doable. I think if anybody could do it, it's going to be Jung Min and S.J. Park and D.W. Park at Asan Medical Center, who have a history of doing some really amazing clinical trials. So I'm looking forward to it. I'll be excited to hear what the study design is ultimately, Jung Min.
There's a question that came from Dr. Saif, and he's asking about reproducibility of the diagnostic criteria of vulnerable plaque. And I think, Jun, I'll leave that to you.
Yeah, this is a very important question. So we can use the 4 different devices: Grayscale IVUS, VH IVUS, OCT, and NIRS. So I do believe that the morphology criteria, minimum lumen area, and plaque burden is very reproducible. And NIRS just to tell us that the number very reproducible. The problem is OCT. So some OCT expert criticized me, but even for me, I did a lot of OCT evaluation, but the interpretation of OCT, it looks like very challenging, even to me. So even though we compare the on-site criteria and QRF criteria, the difference is only 10%. So 90% consistency between the on-site and QRF analysis. So I do believe that this is a quite high reproducibility in the clinical trial.
And I do think it's a very important question to consider as if and when this becomes something we're doing in practice, because again, the ability to properly interpret and use the imaging data is part of that whole skill of the interventionalist who's there. I do agree with the Jung Min that many of the criteria they used are by definition quite reproducible. And with AI applications, as you know, and image processing getting better and better and better, even the OCT, I suspect at some point will be able to be automated. And maybe Jung Min, again, you're doing wonderful things with OCT, so I'm counting on you guys to make this so dumb, so foolproof that even an American can do it. That would be good.
So I'm still going to try to ask a few questions that I think may help investigators. So one of them is, when we look at a treatment, whatever it may be, how do we design a study that looks at the cost effectiveness of that treatment? So let's say we're looking at, the PREVENT trial design. We've established the safety in this trial. We know that it is actually safe to do these procedures. Now, how about, are they cost effective? How would you do it differently, and what parameters would you use?
So I don't think so cost effectiveness is really something, it's very important. It's especially important when you talk about prevention, because again, we are talking, the numbers needed to treat here to prevent one event are, on the high side. You have, if we look at the primary endpoint, over 2 years of follow-up, we had an absolute risk difference of about 2 to 3%, which means the NNT is in the 35 to 50 range. What the only things I would do differently, I mean, I think it would need to be, you have to have the endpoint be a patient-centered composite, because cost effectiveness doesn't really care, which vessel the MI happens from, or the repeat revascularization. So that would be very important, that we have a primary endpoint that is clinically centered, patient-centered, as opposed to vessel-centric. And then it would be a matter of collecting the proper data from the patients over the follow-up period, including, most importantly, resource utilization, what we call downstream resource utilization. So we would collect, of course, the upstream, what does it cost to do these preventive PCI procedures, by collecting all the information about the number of stents and imaging catheters and wires and time that was involved, and those can be assigned costs, and that can go into the sort of numerator of our cost effectiveness ratio. But we also need to look at what are the benefits downstream on the cost side. So any follow-up testing, procedures, hospitalizations that occur. And then we need two more things. We need to understand the patient's quality of life, because we certainly have not proven that we're saving lives here. So when we're not saving lives, we need to understand, is there a quality of life benefit? And then the last thing we need to do, which is in some ways the trickiest and the most uncertain, I would say, is what are the longest term consequences of avoiding the events? Because ultimately, that's what a preventive PCI procedure is. These patients are presumably not having symptoms from this lesion. Their FFR was negative, so you're not going to change their symptoms in the short run. But you're preventing an MI. And what is we will have to use epidemiologic data either from the trial or from other studies to understand what is the prognostic significance of having or not having that MI going forward. And then we would need to model that, extrapolate that benefit over the patient's lifetime. That would be the way to do that. All of those things, it's just, it's careful data collection of the right things, and then careful math in modeling what goes forward. But these methods are increasingly accessible to people. The last thing I would say, very, very important, is anytime we do cost effectiveness, it applies to the healthcare system in which the procedure is being performed. And so the answer as to whether this is a cost-effective intervention may differ dramatically across different countries and different regions of the world. The United States, it may be one thing because our PCI procedures are expensive. On the other hand, our downstream events are also more expensive. In Saudi Arabia, perhaps it looks very different. The interventions may be cheaper, but the follow-up events are also less costly. So it would need to be looked at from a variety of different perspectives, and we would not be surprised to see that the results differ across different societies, different healthcare systems.
I do want to thank both of you, but I want to end with one final question that did come from the audience, Dr. Al-Harbi, who's asking about, will we move more towards intracoronary imaging and imaging in general to replace clinical, I guess, status is what he's saying, but I think clinical implications. And I think it's a perfect question to ask before we close, because ultimately this is an imaging trial that is telling us to stent patients for prevention.
Thank you. So the very, very difficult question to answer. But first of all, so I do believe that the clinical information is way more important than any kind of a specific information from the device or other things, because we are clinicians. We treat the patient as a whole, not treat only the follow-up plaque on itself. But so it's kind of art. Before we call it that the medicine is art. But in some point we need the science. So the art we can do orchestrating the many information from the specific science. We can make a good art, I think. So we cannot replace the intracoronary imaging from the clinical information, but intracoronary imaging provides us that the many scientific information. It can help to lead us to the right direction. It can help to change our decision more appropriately during the procedure and during the patient follow. Thank you.
Well, thank you. I'm just really excited that our journal club is gaining momentum. We have over 212 attendees. And the most exciting is that we're actually spanning the whole globe. So we're coming all the way from Asia to the Middle East and to the United States in one session. And so just crossing borders with science, and it's really exciting to see that. So thank you both for being here. And I want to thank our viewers as well. We do have another one coming up in January, so stay tuned. And David, Jim, anything from your ends, please?
I want to second your your promotion of the multinationality and all the different quadrants of the world here. We have Jungmin, who's joining us in the evening from Korea, me early in the morning. The sun finally came up while we were doing this call here in New York, and you from the Middle East, Mirvat. So I think this is a beautiful image of the three of us on the screen here right now, showing how global our community is becoming, and how research done in one particular part of the world can really expand out to the entire rest of the world through things like Zoom meetings like this, and through obviously from in-person meetings as well, both the TCT Middle East and the TCT Asia Pacific. I think this is TCT worldwide here.
Absolutely. Jun?
So thank you, Dr. Mirva. This is the first, I think, that the first presentation from the TCT Middle East. So thank you for having me, and then I hope the more time to join the doctors from the Middle East. Actually, frankly, nowadays many doctors, two doctors, Dr. Aziz and Dr. Kosadi from Saudi Arabia, worked for our hospital 2 years and came back to Saudi Arabia. So I hope they have a good, brighter future.
Thank you, everybody, and see you again. And I'm waiting for your submission for TCT Middle East. I will hound you.
Okay.
Yeah, sounds
right.
like that will be a good one. Jungmin always has fantastic science. I think if whatever you get, you should take.
Yep, I will. Take care, everybody. Thank you so much.
Have a great day.